Okay, we are live right now. Good evening, Dr. Chytra.
Hi, Dr. Noury. How are you?
I am fine, thank you. It's a great pleasure to have you in this webinar. Thank you for your time and for indulging us with this time to get us a little bit of your knowledge. Let me first introduce you. Today, my guest is Dr. Chytra Anand. She is a consultant cosmetic dermatologist and a multi-award winning. She is also the founder and CEO of the Kosmoderma Clinic. Dr. Chytra, she is actually well known to be a beauty doctor in India. She has a lot of experience in injectables and in skincare. She attended as a speaker in a lot of conferences and courses. So I think that we are truly honored, and it is a great chance for us to learn from her. Dr. Chytra, I'm gonna speak in Arabic for a few moments. مساء النور، يا رب كلكم تكونوا بخير. أنا بعرفكم نفسي. أنا الدكتور نوري عادل، أخصائي جراحة الفم والوجه والتجميل، مدرس مساعد في جامعة مصر لعلوم التكنولوجيا. النهارده ضيفتي دكتورة شيطرة، دكتورة استشاري تجميل جلدية من الهند. دكتورة شيطرة برضه هي مؤسسة وصاحبة عائلة كوزموديرما كلينك. عندها خبرة كبيرة جدا في مجال التجميل، يا رب تقدروا تستفادوا منها النهارده. بشكر دافن مارك على الادفرتايزمنت اللي عملوها والبوسترز اللي عملوها بحيث ان هم يسوقوا للموضوع على الفيسبوك. وشكر خاص للدكتور مينا. So Dr. Chytra, I'm back to you right now.
Okay.
Actually, there's a delay in the sound, so I'm gonna like ask you the question, and you're gonna like wait for a couple of seconds, and you're gonna give me an answer. So let me ask you at first. Like it's always number one whenever you have a patient in your own clinic that you do the patient assessment and patient analysis. Sometimes the patient comes to you says that she's complaining of a certain feature in her face, and you think like, no, I may not treat this area, but I may treat other area, and may give the same result. So it's actually very important and crucial for a clinician to know the principles and the ideal facial proportions and how to do the patient assessment. So could you tell us more about this?
Right. So first thing, when the patient comes in, we have a long questionnaire for them to fill out about what are their problem areas. Have they had these procedures before? If they've not, have they been thinking about it, and for how long have they been thinking about it? And then we do a 3D facial analysis in my clinic, and that picture comes to me before I actually even see the patient. So I see that, and then the patient comes in, and then I start off basically with asking what they're there for and what's like their idea and what's bothering them. And I'll listen completely to what they have to say. And then I'll say, okay, now let me do a bit of a facial analysis for you. So I tend to have them hold a mirror in front of their face, and I'll stand behind them so that both of us are looking into the mirror. And then I'll start explaining the different facets of their face and what I see as to be the problem area and where the origin is and what's the cause, what's the effect, and explain it in detail. Like it could be as simple as somebody saying, I just want my nasolabial folds done, I want a line. But, you know, with advanced training, everybody knows that just going in and doing the lines is not a good technique anymore. You need to fix the cause, which is the facial fat pads in your mid-face and your lateral cheek areas. So how do you explain this to the patient? So that's why I stand behind them and I'm like, see, this is what happens if we pull this up, this is going to go back. But if we look at the descent, and I'll show all the vector movements on their face, and that gets them to understand what I'm explaining. 99.9% of the time, patients are willing to go with my approach when I've explained it this way. Now, if there are still some who are resistant and say, no, I only want this fixed, just do only this, then I'll explain to them that building a face is like building a house. You know, you've got to start with the foundation first. And once your foundation is strong, then you put up the walls and then you paint it. And I say that what you're asking me to do is to go ahead and paint it. when there is no foundation. So it makes no sense. And so I've always found that when you use these kind of topics to discuss with them, they understand it much faster. And I never ever do something that I don't believe in. So if that patient says, I'm going to walk out if you just don't do these lines, then I'm like, okay, then you might be better off with another doctor. And I will send them off because that patient's never going to be happy with those results, anyways.
And actually, you came up with a very good what you said right now, that there's always this concept of indirect beautification. You just don't need to fill a line. You may treat the cheek and you may lift this area. So it's like dealing with the face as with its subunits, and it's like you are not focusing on this area that you're going to treat. Okay, let me ask you: do you think that patient nowadays have the full knowledge about what to do? I mean, they come in your clinic and say, "I want to do Botox, I want to do filler," or you just have to explain them. When do you do Botox? When do you do filler? When you decide to go for a thread? Um, so tell me more about this.
Sorry, did you ask me when I choose or when patient chooses?
Actually, the question is consists of two parts. Do the patient have now the knowledge of what to do at this area? I mean, do you hear it like, I want to do Botox here? Or still
Right.
some patients don't know what the product to use? And second, when do you decide to do Botox and when do you decide to do filler?
Got it. So I think it's a mixed question. The reason is that people kind of understand what Botox is, but they don't know what Botox does, nor do they know what fillers does. Let's say out of 10 patients, maybe 2 patients, so that's 20%, might walk in saying that I want my lip filler done or something like that, or saying that I want Botox done. But most patients, we need to educate. So it's usually that they walk in saying that I have a problem, what can we do? And then we choose to say, okay, we're going to relax your facial lines with Botox and we're going to give you some volume with fillers to support your facial structures. And that's how we build it up. It's very rare that we would see a patient saying that I want Botox here, I would like some fillers here, etc. It's not very typical here yet. Most people are most familiar with lip fillers. Beyond that, they don't even think too much about that whole concept. Now, when do I choose to do what? Well, it depends on the patient in front of me, really, because what I'm looking at, because, I'm a dermatologist, so I'm going to look not just at the bones, but I'm going to look all the way to the skin tissue. There's only so much that volumization can do for you, and that anatomic subunits, as you spoke about, there's only so much volume you can put in there. Beyond that, they're not going to lift anymore. And if you do all of this, but if your skin texture itself and the tone of the skin is not healthy, nothing's going to hold up. It's all going to come right back down quite fast, and your patient's never going to be happy about it. So when I look at the patient, I'm looking at the thickness or the thinness of the skin. The thicker the skin, the better the results for me, as in lasting results. The thinner the skin, the faster they tend to break this down, the products. And what I like to do is I like to get a little bit of collagen and elastin building into the skin. So what I do is I do the stretch and I pop it. If the skin just pops right back, I know that the skin is healthy, so I'm good to go with just Botox and fillers. But let's say I do this and the skin comes back slowly like that. I know that the reflex, the stretch is gone. So
It's
how
like
much is that skin?
the snap test that is done on the lower eyelid, you mean?
It's just like the snap test, but it's a stretch here because you're just stretching the skin and seeing how fast it goes back in. So you're looking at the elastin and the collagen both. So when I look at that, that tells me if I need to work on the skin. And if I do, then I will think of adding threads to the program. So I'll do Botox fillers and then put the threads in. And then I'll even look at energy-based devices like alt therapy. I have alt therapy, so I use that, or I use thermage, So these are the things I would add into this treatment. Or if they couldn't afford alt therapy, I would even do a microneedling radio frequency device.
You use the high function therapy at your clinic. Actually, we want to tell our audience because they are dentists. therapy and high intensity focused ultrasound. They work as a thermocoagulation for the dermal layer, so to add to tighten the collagen. Maybe some of our audience won't be actually very familiar with those devices because it's actually used by the dermatologist more
Right.
likely.
So these are
I
devices
want to
that
ask
we're
you about
using.
something. Actually, you said something.
Sorry, I was just saying that these devices are devices
I
for
want to ask you
collagen
about something you actually
stimulation.
said right now. Exactly. You actually said something that it depends whether it's a thin skin or thick skin. So do you agree with me that the best filler product won't give you any good if you do have a bad quality skin?
Yeah.
So as a dermatologist, and you are one of the pioneers, did you hear what I said, or you missed this part?
Yeah. Skin quality is extremely,
Shall
no,
I
no,
repeat
I'm
it?
good,
Because
I'm
there's
good,
a
I'm
sort
good.
of rule of thumb.
Skin quality is extremely important. The reason being that, you could do everything, but if that skin, when you look at, doesn't have health, doesn't have vitality, doesn't glow, doesn't shine back at you, there's no point. It's like somebody, you've done all of the Botox, you've beautified them, but let's say they had bad acne or bad pigmentation or open pores or a dehydrated look with like a very scrunchy looking skin. It's never gonna look great. For that face, which is your canvas, to look beautiful, you've got to look at all the layers too. And because your Botox and fillers works on the muscles and it works on the fat pads and on top of the bone, what you're looking at is the internal changes. But external reflection is your envelope, so that's the skin. So it's very important that you take care of the skin texture too.
Actually, with the facial muscles, they are mimetic muscles. They are muscles that attach to the skin. It's not like the skeletal muscles which have an origin insertion to bone. Whenever the skin loses its elasticity, it's definitely gonna affect how the speaking about Botox and fillers, what is your favorite neurotoxin, and what is the available neurotoxins in India, and what is also your favorite filler material and the available filler material? Because I think not all products are found in all over the countries. Some countries have products other than others, and so on.
So for neurotoxin, we've got Botox from Allergan, we've got Dysport from Galderma, and we've got Xeomin from Mars. We've also got toxins from Korea. And so these are typically what we have. My go-to product has been Botox for a long time. The reason for this is when I first trained, I trained with Botox and Dysport. I used both when I was in England, but in India, when I returned, we only had Botox. So I just got used to using Botox for everything. So it's just easy for me. I don't have to think too much about it. Now, sometimes I will use Dysport in certain patients, especially if I'm trying to do like forehead lines and there's some low-lying lines about the eyebrow, the brow area, then I'll try and use Dysport. I use Dysport for hyperhidrosis and stuff like that. But typically, my go-to is Botox from Allergan. Now, for fillers, we've got the whole portfolio from Galderma, Allergan, and Merz. So we have Voluma from Allergan. We have Volite, Vollift, Ultra Plus. And so yeah, we've got and Volbella. So we've got all of them. Whereas from Galderma, we've got Restylane, Perlane, and then we've got Skin Boosters, which is the hyaluronic acid, which is one of my most favorite products for skin tone and texture. Because with fillers, I always put skin boosters in the skin because it hydrates the skin and the skin looks a lot better. So that's my go-to for hydration of the skin. Then we've got Merce, and Merce has Hydro. Right now they don't have it, but Hydro is also a very popular product, and I love it, especially for the neck area and for the face for just the skin hydration. I love Hydro. And so they have the whole Bulletero range. Now, my favorite products, I again use more of Allergan fillers, but in Galderma, I like Restylane Lift or Perlane, especially if I'm doing like the chin and if I'm doing the lateral zygomatic arch. That's my favorite product for that. And for the whole other things, I use a lot of Voluma. I'm one of the largest users of Allergan products in India. So I use a lot of Voluma. I use Volef. involve Bella, especially around the eyes. And I do like Ultra Plus. And I like Ultra Plus in the lips. The reason is Wall Lift is beautiful, but what happens is it gives a softer texture. But what happens with Ultra Plus is it gives that nice firmness and you get a bit more volumization. So I actually use more Ultra Plus in lips than Wall Lift presently.
Dr. Chytra, do you have the injectable form of Botox? I mean, Botox comes in a vial with hydrophilized particles, and you do reconstitution with saline. Actually, there is
Yes.
a brand which is Bocature and Inotox. It comes
Yeah.
as a liquid form. Do you have the liquid form
Bocature is
Botox? Is it
Xeomin.
available in
So
India?
Bocature is called Xeomin in India.
So is it available as a liquid form?
Yes. Ready to use. And you can keep it outside. You don't need to put it in the
Okay.
fridge.
Exactly, yeah. Speaking about neurotoxins, actually, you do agree with me that this sport, the researchers have proven that it has an amount of active toxin per molecule, which is, if I do remember well, it's like 0.27. So it's theoretically speaking, it should be like the better neurotoxin, or it should be lasting longer. On the other side, or the dark side of this sport, some people claim that it has a high diffusion rate. So you may have a brow ptosis if you inject it in the forehead. Do you believe in those claims, or it's not something to blame the materials? It's something depends on
No,
the clinician who's injecting.
I think in our practice, the data is there, but I don't think it is of that tremendous consequence in our practice. And diffusion is about the amount of saline you're using to reconstitute your toxin. So I think it has to do more volume based than it has to do with like the toxicity or the content or the potency of the toxin that we're talking about. And the toxin content is really low. I mean, it's really, really low in the 100-unit vial. It's more that we have to be concerned more with the albumin content, which is probably more reactive to patients very rarely, but otherwise no. And I think diffusion is volume based. It has nothing to do with the toxin per se.
It depends on the amount of saline you use it in the reconstitution procedure. Do you
Yes.
have the non-cross-linked fillers such as high lift
Yes.
and those? Do you use it? Do you think that they are good or they are not that much?
I use non-cross-linked only for skin hydration, because if it's non-cross-linked, it has no texture or tonality. It's not firm. The G prime is very low, so it's not going to hold any structure for you. So I don't use it as a filler at all. I use it as a hydrator for hydration.
Okay, I see. Doctor, could you give us like a little bit of tips and tricks for a homemade recipe or certain diet that we can do to take care of our skin? I saw earlier at a YouTube video of you were talking about the sunblock and SPF, and that regardless whether it's winter or rain, you should always put your sunblock because actually the clouds do heighten 80% of the ultraviolet rays. Just if you are, especially nowadays, a lot of people are sitting in their home, so they can do those home made recipes to take care of the skin. So could you tell us more
Right.
about such things?
So I always tell everybody, I mean, no matter what it is, just stick to the routine that you have. If you're cleansing, cleanse your skin, and if you use a toner, tone the skin. But typically, few most important things: don't use soap on your skin, because soap is dehydrating on your skin, and you want to maintain that skin pH and the skin barrier. So use a soap-free or a pH balanced cleanser to wash your face. Next, it's not necessary or compulsory that you must tone your face. There's not necessity about it. But what you must do is use a sunscreen in the daytime. And people say, oh, I'm in the house, I'm not stepping out, why do I need a sunscreen? Well, it's about radiation. If there's light coming in through the window or the door, that's enough to damage your skin. So you should use a sunscreen even when indoors. Plus, we're in front of the computer screens a lot and in front of our mobile quite a bit. So that's also radiation. So you must protect your skin using a sunscreen. sunscreen, SPF 30 is good enough for a daily basis when indoors. SPF 50 if you're outdoors is what I tell my patients. Second, I talk about moisturization. Now, if you have an oily skin, you don't necessarily need to moisturize. You might just need hydrator. So a hyaluronic acid serum might be more than enough for you. But let's say you have normal to dry skin, then what you must do is you must use a moisturizer to protect your skin from dehydrating and from the oil getting leaked out from your skin. So that's why I say use a moisturizer more like a film barrier than anything else. And that's at night before you go to bed. You don't need to moisturize day and afternoon and night unless you have very dry skin. If women are over 35, I typically tell them to use a retinol based product on their skin, at least a retinol 0.05. The reason is you need to increase your cell turnover rate. Like normally, the cell turnover rate is every 28 to 38 days. But as we get older, it gets sluggish. And the more sluggish it gets, the more dull the skin looks. The pore sizes start to increase also because of loss of muscle tone in the skin. So it's important to have some kind of an activation. So I say use a retinol, at least 0.5 on your skin. If not, you could use a prescription-based retin-A or tretinoin once or twice a week on your skin to keep that activation going. Next, I also tell, like, if you're a woman, then if you're over 35, there are hormone changes going on. So use products with soy or bioflavonoids on your skin because they have like an estrogenic capacity, and they'll calm your skin down because you're now getting perimenopausal and then menopausal, etc. And for the men, they shave every day. Shaving is the best anti-aging treatment you can do for yourself because when you shave, you're exfoliating your skin. That's why men have smoother skin than women as people get older. It's sad, but it's true. So these are the few things. Then I also tell people what you take. It's not what you apply only, it's what you take also that's equally important. So I always tell them take your nutraceuticals, which means take your antioxidants like alpha lipoic acid, ubiquinone, polypodium, which is a fern extract which boosts your skin's protection against the sun. Make sure you have enough vitamin D and B in your system and stay healthy. So if you can do this, you will have great skin maintenance routine.
Doctor, actually, they called me right now and they told me that there's a problem in your voice. It's actually like it's cutting off. Okay, I can hear you well right now. There's like sort. The sound is like there is. I don't know what to say. Like
There's a
clicking or like
disturbance.
scratching your own
Yeah,
sound.
there is. I don't know what it is. There's
Yeah,
some
yeah.
disturbance.
Okay. So speaking about skincare, could you tell me more about mesopotox?
Right. So meso or micro Botox is something that we use for textural changes and to decrease the oiliness in the skin. So what we do
So
is
like by
basically,
injecting it in intradermally.
yeah, so we use Botox or Dysport, but we'll use a neurotoxin and they'll hyper dilute it basically. So if your normal dilution is 1:2.5 cc, we would probably do a 1:5 cc dilution on this. And what we would do is then inject it 1 centimeter apart along the cheek, along the chin, and in the forehead area and the nose. Now, what this does is it works on your oil glands, so it decreases the seborrhea or the oil, and then it also works on your erector pili muscles, so it relaxes the erector pili muscle, which then makes it smoother. So your skin, the open pores reduce, it looks smoother, there's less oiliness, and you get a shine to your skin. Typically, the results last between 6 to 8 weeks.
Do you combine mesopotox with other procedures that you do, like the hypho or para, like you took a little from a little of
Yeah, I always combine all my procedures. I never do one as a standalone because nobody really, I mean, not nobody, but very few people have just one issue. If you actually examine their face, you'll see that it's multiple issues put together, and you've got to treat the entirety of the face, not just one area. So what I do is, if I had to do lasers, I'll finish the laser and then do the Botox and fillers, like fillers first and then the Botox. So Botox is always my last procedure to end the treatment. But I don't typically do threads and fillers on the same day unless the patient is from out of town or there's a paucity of time. I like to space 2 weeks apart between the treatments.
Doctor, actually, they are complaining from the sound. I don't know what is the problem, but
I don't know. I
let's
think
try
it's
to
the
fix it.
internet connection, I
Can you
think.
put? Okay. So, okay, we are actually trying to do our best. Okay, so let me ask you another question. You were speaking about facial threads that sometimes Botox and filler alone may not give you the benefit or the result that you are seeking, and you have to do facial threads to give this lifting for the mid face. When do you use it, and what is the dark side of facial threads? Because they do have other complications also. They are not like uh, 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 something that everyone should go on for.
So I combine all these procedures. The threads that I use, we have a lot of PDO threads in India. So I use PDO threads, which are plain PDOs. Then we have PDO with cones. I use both. We also have cork threads. So those are the thicker ones with cogs in them. I use those. We also have Silhouette Soft, which is like a polylactic acid thread. So I use that too. Now I save my polylactic acid thread for people who are over 40, 45, who need textural changes, visible textural changes in their skin. Whereas I use the PDO threads and the cog threads for the other patients. So if someone's as young as 30, I'll use a PDO or cog thread. But older than 45, I prefer the Silhouette Soft, which is the polylactic acid threads.
Speaking of young patients and the millennial patients, and you were speaking about lip fillers from a while ago. Does your patients are seeking a natural looking lips, or they come and seeking the Russian lips and those strands of 50-50 upper and lower lips? What is
Right.
actually they are seeking?
Most people like it natural here. Like 99% of them like it natural. And it's a big taboo to discuss your lip filler. So nobody wants to talk about it. But the thing is, there
Actually,
are
I
some
do
out
I
there.
do have a natural 50-50 actually.
But some of them are like outliers where they really want to get their lips done and they want to have like those bigger lips, like a Kardashian lip or something like that. And we do our best to dissuade them, to tell them that this is not the ideal shape, it doesn't suit your face and everything. And we will try and most times dissuade the patient from having that done. We only do it to what suits their face structure.
This is a bit, because actually it's making a trend right now. All the patients are seeking Russian lips, and this is should not be the norm, because this is not like the normal or the ideal features. They are like a lot of people are seeking the fake look. Let me take you back to fillers. You mentioned the several type of fillers that you use. Do you believe that most of the clinicians should head for a filler that is based on hyaluronic acid rather than a filler that is based on a polymer or calcium hydroxide? Um, or- well, let's say that filler that's based on polymers, they are a very, very good technology, but poorly misunderstood. They should be placed on a subperiosteal level, but some people do place it subcutaneously. This lead to nodules, a lot of things. Do you think, as being an experienced injector, we should always seek a filler with hyaluronic acid base rather than fillers that is based on polymers?
So I think it depends on the injector, their experience, and the safety. Now, we all know that there's possibilities of vascular incidents, be it rare, but it's a possibility. And should you get it with a hyaluronic acid, at least you have an antidote. You can use hyaluronidase and try and salvage the patient's skin and the vascular structures in that area. But if we were using polymers, they're longer lasting. As long as you know which are the safe zones and you're using it in a safe plane and the safe zones, you're okay. But let's say there was an adverse event. There is nothing you can do to reverse that adverse event. It's not like you can even cut up and pull the filler out because it's going to disperse and cause fibrosis in that area because polymers work through fibrosis. But saying that, polylactic acid Sculptra is a fabulous product. I would not call it as a filler. I would call it more as a biomodulator because it causes skin collagen production and skin remodeling. Same thing with Radius from MERS, the calcium hydroxyapatite. It's a fabulous product. It's great for doing the chin and the jawline, zygomatic arch and stuff. But as long as you know you're in the safe area, you're in the safe zone, it's safe. But if you're a novice injector or an intermediate injector, be cautious and try and stick to hyaluronic acid. As you gain a lot of experience and you're doing a lot of products and you know that your anatomy is very good and you know exactly where what lies, then proceed with polymers.
I see. Okay, so let's say if you are gonna like take the face from top, the bottom till the chin, what is your own Chytra tips and tricks in injecting the forehead?
Right. So in the forehead injections, I always get my patient to actually put their head down and keep it down for about a minute. And when they lift up, some of the arteries and vessels will pop up, and I mark those out. All right. So that's what I do for the forehead typically. And then I use a cannula, and I also use a needle depending on the patient. If and then I tend to bring in my cannula from the lateral side. Initially, I used to work from the superior side, but now I come in from the lateral and fill in this area. But you know the anatomy, right? You got to stay extremely superficial in the or almost intradermal in the lower part of the forehead, and you have to stay deep on the bone, bevel of your needle facing down on the superior surface of the forehead. Your superior injections are safer
Yeah, exactly.
than your inferior
Because the
injections.
arteries are deep in this area, but you are superficial in this area.
Yeah, so
The
you've
arteries
got
are
your
like deep in this
supratrochlear and
area,
your
and then they go
supraorbital
superficially here.
arteries right here, the complexes which go in. You have a central vein going through here. From here, you've got the anterior branch of the superficial temporal artery coming through. You have a sentinel vein in this area. So it is a fairly vascular area, so you've got to be cautious when you're injecting the forehead. I never tell people to inject forehead at least until they've at least done 2,000 injections in other areas of the face and they've done a specialized anatomy or a cadaver dissection course. That's the only time I tell them that, okay, you're ready now, then you do the forehead. Otherwise, you need that much experience to get there.
The temple area.
Right, in the eye, periorbital and canthal area. Now, I do the upper also, and I do the lower. When I'm doing the upper, just in the brow area, I use a cannula. For this area, I use a 25 gauge cannula. But for the lower, which is the tear trough and then the palpebromalar junction, etc., I always support the mid face first. So I would actually do the lateral cheek and then the mid cheek, and only then come and fix the eyes. I never work around the eyes without fixing the temporal, without fixing the lateral cheek, and without fixing the mid cheek, because these are supporting structures to your eye. Once that's fixed, in the same session, I'll then come in and then do the tear trough. I still use needle most commonly to do the tear trough injections and to do all my temporals and mid-cheek injections. Sometimes if a patient's quite flat-faced and I have to create a tanjection of the zygomatic bone here and create the whole Uji curve effect, then I will layer up my fillers. So I would do the first with a needle on the bone, and then next I would do a deep dermal mid-subcutaneous with a cannula. So that way I layer the fillers to get that curve going.
normal anatomical layers. It's like 3D. Okay.
I couldn't hear you.
Okay, it's like you are building the filler in layers imitating the normal layers of the skin. It's like a 3D facial approach.
It
Doctor,
is.
when you do the nose, do you have a certain tips and tricks in doing the liquid nose job?
So when I'm doing the nose, I assess the nose from the frontal and the profile. Now, with the nose and the forehead and the chin and the lips, these areas, the profiloplasty is extremely important. So I always look at the profile of the nose, and I always start at mapping the radix. In a lady, the radix has to be in the level of the eyelashes, whereas in the guy, it can be at the supraorbital ridge level. That's what gives a masculine nose. So if the radix needs definition, I will define the radix with a needle. I will insert it top down and work this way for the radix. And I will always pinch the nose when I'm injecting in that area. And then for the dorsum of the nose, I tend to use either needles or cannula depending on how much work is needed. If there's a dorsal hump and that requires connection, then I will use a needle. But if it's just to give a dorsum a smoothing and to give it a bit of stiffness, then I will use the cannula, a 25 gauge cannula, sometimes 22 gauge cannula commonly, and just stay on the central part of the dorsum, and then do an slightly two lines, but all in the central part, and then mold it. Then I come and I do the tip and the supra tip area here, which I use a needle. I intend to insert the needle from the columella and bring it all the way through, and then give the entire foam and stiffness to the nasal ridge. That's the only way I'm able to define the nose. I always also do the injections into the
I want to
piriform
ask you
fossa.
about prophylaxis. Actually, when you do have a deviated nose, regarding the anatomy, we shouldn't be injecting along the lateral side of the nose because of the nasal arteries. But when you do have a deviated nose, could you just inject superficially along the lateral bridge of the nose?
No, ideally you should not go towards the lateral side much. The reason is all of your vessels and arterial and vascular supply is lateral. The safest is the central part of the dorsum. Then I also inject into the piriform
Okay.
fossa right
So,
here, deep on the bone. The reason is that that's what's going to give the L of the nose a bit of narrowing and to give you support in this area. So this is how I complete a nose.
yeah, and actually they do the same thing as a myomodulation in gummy smile cases. They inject filler at this area also to alter the muscle activity in a sort of mechanical obstacle. Am I right?
Yeah.
So tell me, what is your favorite techniques or special techniques in doing lip fillers?
So for the lips, I almost always line the lips because unless they're very young lips, I always find that the lip borders are never well defined enough, and there will always be a little bit of softening. So I never go straight in and then do the lip into the mucosa or in the junction of the mucosa. I always start with the lip line, so I go the opposite. After I've done the lip line and then the accentuation across the entirety, I also always leave about zero point 0.5, about 5 millimeters to the corner and then start. I don't take the lip corner definition till the end. If you do that, then you tend to get like a Joker kind of appearance when you smile. Your lips tend to do that. So I always leave about 5 millimeters from the corner and then start. That's one important tip. Second, if you need a lot of volume, then the safest plane for me to inject is superficially in the junction between the dry and the wet border. And that's where I do a lot of the injections for volume. But first, line it and then give the volume. The lips look a lot better than just giving volume. That's what I do. And in the younger patients, I will define their philtrum In older patients, I don't try and define the philtrum except for the first 25%. I never go all the way for a philtrum definition in older patients. That keeps it natural.
I see. Actually, I saw this webinar before between you and Dr. Shinopei, and you were speaking that most of the Indian patients have always, you are always like focusing on treating the periorbital area and the perioral area. It's like most of them do have this orthognathic problem. And actually, we do have the same thing here in Egypt also. I guess it's like aesthetic. There's this like aesthetic feature. Do you agree with me that Botox and filler have like gave a perfect alternative as a camouflage line of treatment for patients who have an orthognathic problem? Nowadays, they don't have to go through orthognathic surgery and GA and to have hospitalization. With a couple of Botox and filler, you can do a camouflage and give the same result. You are restoring aesthetic, not function, but at least you are giving same result. So, do you agree with me in this aspect?
I think to a minor degree, we can do that. Like before, if you had a gummy smile, there was nothing you could do except look at surgery, right? And because you're from the dental background, you'll know that better than me. But now we can camouflage that by doing this. Same thing with bruxism, right? When you had bruxism and you had the masseter hypertrophy, it was surgical that people had to go to surgical resection to get the bulk down. But now you can just use neuromodulators and shrink that down. So I think by using fillers and by using neurotoxins, we can definitely give a lot of hope to the people who require the minor corrections and stay away from surgery. But in case of like a lot of orthodontic work, like people who need braces are always going to need braces.
Exactly. So it actually depends on the case, but it always gives a better alternative. Speaking about gummy smile, where do you inject? I do inject at Fiancé point, which is a point 0.1 centimeter from the ala of the nose, and sometimes I may give across the insertion of zygomaticus major muscle if she have a mixed gummy smile. I mean, if she have like the lateral part of the lid like
Yeah.
lifting too much, where do you like to make your injection? And how do you calculate the dose? By the way, my master's thesis was about gum smile. I studied different modalities and treating gums.
So what I do is I ask them to scrunch like this, and wherever they scrunch, I hold the muscle. That's the elevator labii superior aliquinesi (LLSAN), and right there is where I give the injection, and it's 2 units to 4 units per area when we're using 2.5 cc dilution, and that's what I do with Botox. That's what I typically use right there. If it's an exaggerated gummy smile, I'll even go up to get the nasalis out because they become accessory muscles eventually. And then I do see the smile. If it's a broader, wider smile, sometimes if I need to knock out the zygomaticus major, I'll just go straight down from the lateral canthus of the eye at the most prominent eminence of the zygoma, and then just go right through and inject right there. That gets the zygomaticus major muscles for me. But I just do 1 to 2 units in that area because I don't want to knock off the major muscle in that area. I also observe the kind of smile it is. Sometimes I even work with the orbicularis oculi in the lateral and the lower inferior part, because sometimes softening the orbicularis oculi muscle, which is a cheek elevator, will also help with the gummy smile. So this is how I look at it.
Because sometimes the patient have an orbicularis oculi, which its muscle intermingles with the zygomaticus major. But actually, you have opened up a certain an important point. I choose to hit the zygomaticus major at its insertion across the nasolabial fold, because sometimes when you do injection at its origin, you may have a little bit of cheek ptosis here. So I choose to hit it from the
Right.
insertion area. Speaking, okay, speaking about perioral area, do you do a lip flip or lip plumping with Botox?
Yeah, sometimes for the perioral lines, and if somebody has a floppy upper lip, then I will do the perioral Botox right here, 2 units and a 1 unit here. Same thing here, 2 and 2 units or 2 and 1 units, because what that does is it causes an aversion of the lip, and so I would use Botox to actually evert the lip.
But it should be very minute doses because you may hinder. Do you do Botox for the
Yes,
mentalis?
and it becomes hard to say. Mm,
Okay, and do you think fillers in, yeah, and fillers in the chin area are actually perfect? They can aid in helping cases with rhinognathia when they do have a retreated chin.
yeah, fillers. I love chin fillers. I mean, it gives you that oval shape. You're able to, increase the height, decrease the width. You're able to slim down a face, narrow a face. It's so critical to look at the chin and then the jawline to keep that total sharp jawline, because youth lies in sharp jawline. And of course, so I love fillers here, but I also use a lot of neurotoxin here because mentalis gets hyperactive now in a lot of people. And if it's hyperactive and it's puckering, it's always going to pull the chin down and you're not going to get a great profile. So you need to relax the mentalis. Same thing with the DAO or depressor anguli oris. You've got to get that muscle relaxed. Otherwise, it keeps pulling the lip corners down, and that's a negative vector again. Now, I also use along the jawline, and it's right at the jawline and half a centimeter above and 1 centimeter above, three lines, starting just in front of the angle of the mandible all the way till the DAO, or till you've got the mental label fold right here. So it's in this span. I do about 4 to 5 dots of two units at the jawline and 1 unit in the skin about that. And also sometimes I take it down to the neck and do the platysmal bands. What that does is it helps give me that sharp jawline.
Yeah, a Nefertiti neck lift. They call the technique Nefertiti neck lift because of the
Yes.
Queen Nefertiti here in Egypt. She has this
Yes.
chiseled jawline. Yeah.
Yeah.
So I want to ask about something. Do you use filler with the concept of myomodulation, like placing the filler underneath the muscle may aid in its activity, while placing it superficial may render a mechanical blockage? It's something that Dr. Harris do a lot. Do you use it from this concept or just use it as a volume restoration?
Well, see, the thing is, you're putting something in there. It's going to change the natural muscle action and the natural dynamics of the tissue in there, because you're putting something in there which was not there already, right? The dynamics is going to change. Now, the concept of myomodulation is fantastic, but I'm not going to say under the muzzle, over the muzzle, etc. It still needs a lot of technical research. It's not proven nor is it disproven, but I totally agree that putting product in there and supporting tissues will relax certain overaction of muscles. Like, let's say we were smiling, right, and we were pulling this back, but if you had enough of volume in this area and it gave it a support, it's not necessary that you're going to stretch your smile all the way out. You can correct gummy smile even by supporting the surrounding tissues in that area. So I don't know if myomodulation is the right word or not, but definitely by creating support, you can change the dynamics in that area.
And actually, I actually don't get the idea because I don't believe that those tiny little particles of filler may actually alter a muscle activity. I guess it needs a lot of amount of filler, and you cannot place a bolus like here or here or here. So it's like theoretically speaking, it makes sense. When you do it on a practice, it may be a little bit different.
Yeah, it needs more studies. I think, see, if you look at it, it's about lack of support, right? If you're moving and everything was 100%, your muscles are also moving at a certain way. Now there's fat deflation, there's ossification of your bone. You've lost the structural support, right? So your muscles are going to get more stretched, right? So you're going to get overactivity in some areas, underactivity in some areas. So when you put volume back to take away that volume loss, you're actually just supporting the muscles to get back to their normal from where they've come to under tension. So that way, that's the concept, and that would work, right? But I don't know if you're like changing everything around there.
Okay. Speaking about Botox and fillers, do you recommend giving Botox and filler to a pregnant female?
No, I don't recommend Botox and fillers in pregnancy. Well, definitely not Botox. Now, fillers, if you're using just hyaluronic acid, I know it's not FDA approved, there's no studies, but logically, when you think about it, there should be no harm because it's just hyaluronic acid, right? There's no systemic absorption of it. So, in that way, maybe. But have I ever done it on a pregnant woman? No, I have not done it on a pregnant woman. But lactating, yes, but not pregnant. But definitely no neurotoxin.
You see, actually, I do have a point of view about this thing. Actually, Botox is labeled by FDA as a pregnancy category C. So theoretically speaking, it shouldn't be doing anything to a pregnant or lactating female since its particle side won't cross the placenta.
Yeah.
But it's from the psychological aspect. If the female is pregnant and anything happened to her baby, she is gonna blame the doctor who did the Botox, even if the Botox did not cause anything. So it's like we are dealing from the psychological aspect rather than it's like scientifically, it's gonna
Yeah.
really hurt them.
And when there's
Okay,
no data on
speaking
your
about
side, you're screwed.
hyaluron pen, actually we don't use. I didn't never use it as a dentist. Yeah, exactly. Speaking of hyaluron pen, do you use it? Do you believe that materials can be introduced to the skin through mechanical pressure and tissue distension? Do you believe those devices and such techniques
Are
do
you
give
talking about the
a
pneumatic
good service
devices?
to your patient, a good quality?
Are you talking about pneumatic devices?
Okay, I'm gonna repeat it. Yeah, hyaluron pen or hyaluronic acid pens. They are like the mechanical devices which introduce filler through mechanical pressure to the skin, making tissue distension to allow absorption of your filler material or your product hyaluronic acid material.
So we use non-reticulated hyaluronic acid with high pressure
It's like
devices to get it
the
into the
microneedling
top
and such
layer,
stuff. Do you use
into
it?
the epidermis. But I don't believe it's getting to the dermis. But there are those newer devices, the pneumatic devices. I've not used it, so I can't comment on the pneumatic device. But the other high pressure devices, we use them as part of our medifacial routines to introduce hyaluronic acid into the deeper epidermis. Ooh, I think I lost Noury.
Okay, I see.
I think I
I'm with
lost
you,
you.
Dr. Shaitra. Actually, we have a terrible Okay, can you see
So
me right
I said,
now?
yeah, so I said I don't use pneumatic devices, so I'm not familiar with them.
Okay. Doctor, tell me, do you do PRP in your own clinic? There are researchers claiming that. Can you hear me? You lost my voice.
Now I can hear you.
Okay, can you hear me well right now? Okay. Does PRP really work? I mean, theoretically speaking, PRP do a great result in injecting in the hair, but it's not a filler material. Some people think that they will have this vampire facelift and Kardashian trends and such things. Does PRP really work, or it's just something that a lot of clinicians and doctors using it for commercial purpose and to collect money from patients who are not fully understood, who don't fully understand the results of such a technique?
I truly believe that PRP works because we use it not just for hair rejuvenation, but we also use it for skin remodeling. We use it for acne scar therapy. We use it for aging skin restoration, etc. As a standalone treatment, I don't think it's great for skin. It's fantastic when it's combined either with lasers like fractional lasers, erbium glass, or microneedling device. That's when we do it, or we inject it into the skin. And then we do like Q switch or pico lasers for rejuvenation. I believe that way it works very well because it's just about growth factors. All you're doing is increasing the skin turnover and increasing the quality of the skin. I don't think it will replace fillers. It can't. It's not going to lift your skin. It's about skin tone and texture. That's all. It's only going to work up on your dermis. It's not going to work deeper than that. So as long as we understand that we're improving the skin tone and the texture, you're fine with PRP. And I think it's great. We use it for all our acne scar treatments, for all.
Do you use a special kit?
Yeah, we use a kit. We have an Indian pharma lab that's made a kit here in India. So we use that kit.
Because I actually think the test tube differs. Some test tube gives you a higher concentration of platelets other than other test tubes. Am I
Yes,
right?
true that.
Okay. Okay. Speaking about frictional laser and hair laser removal, if the patient is gonna have a facial threads or fillers or Botox, do you delay or make like when do you do the injectable first or the laser first?
I'll finish their laser, their threads, and then do the Botox. Or I'll do the
So,
threads and the Botox on the same day and then do the laser after a week.
did you report any cases that had the laser after filler injection and the filler have just like disappeared?
No, but with HIFU or alt therapy, there are patients who will say that they feel that their filler went down, but I don't know. We've not done any studies on it, so I can't confirm it. But I do feel that it just tightens the tissue, and so that itself gives them a feeling, and that they're getting hollower and stuff like that. But I've not visibly seen it so far.
Dr. Shaitra, actually, we're speaking when we were talking about your tips and tricks. You spoke about the anatomy and how it's very important to know the anatomy and the blood vessels and muscles. And you know that our audience is mainly dentists. And the idea of inviting you actually to this webinar and taking advantage of your immense knowledge and your own experience and long journey in your field, that I wanted to tell our audience that dentists can be qualified to do facial aesthetics as long as they can do their own practice. And so, can tell me more about your own point of view. Do you think that dentists should be able to do facial aesthetic work? What is the limitations? What is the boundaries?
Well, look at it like this, Dr. Noury. We're letting estheticians and we're letting nurses treat faces, right? We're letting them do lasers, we're letting them do other procedures with a bit of training, right? So I do feel that if dental doctors or other doctors, what happens, they've gone through some kind of medical formal training, be it that you did more on teeth itself. But if you've got the brains to study that, you've definitely got the brains to understand the skin, compared to an esthetician sometimes. Because I mean in some countries the estheticians are very good, they're sometimes better than doctors too, but in most countries across the world, esthetician courses are not that rigorous, right? So if they can do it, I think if it's a bridge course, like if there's a 1 month training program or something like that where the dentist can go and do a program, like my academy, the International Academy of Aesthetic Medicine in India, we run courses for doctors, like dental doctors and other doctors who want to practice medical aesthetics. So we train them from the basics of the skin to the hair to understand every level, to do hands-on training. So if you can do some courses like that, I think why not? If your legal association allows you, why not? I mean, you've gone through medical training already, right? I mean, dental, but it's still medical. And if an esthetician can do it, why can't a dentist?
Yeah. Thank you so much. Actually, we have reached the end of our webinar, but I can't end without asking you two special questions. First, I came up with a video of you on the Instagram, and I can't help but notice that you were talking about the boosters, immunity boosters, as like it was like something innovation for Cosmoderma clinics to do the immunity boosters as a sort of like fighting or compacting the COVID-19. Actually, I think you did something that is remarkable, and I don't recall that anyone else have did it. Am I right about this? And how did you came up with the idea? And actually, it's fascinating.
Yeah, so basically, if you look, I'm in one of the, I mean, if you look into all the physicians that are talking about COVID and what's happening, you'll see that, you know, immunity is critical to giving you the fighting chance against not getting critical with COVID, and about how to decrease the viral load and stuff like that. So basically, we came up after a lot of research and everything, going through white papers, going through anecdotal reports, and going through what's happening in the ICUs today and what they're using, like high doses of vitamin C, vitamin D, etc. We came up with the immune booster program at Kosmoderma. That's my clinics at the research center, to help patients increase their immunity, because that's all we can do. I mean, everybody, at the rate it's going, till the medicines come, I don't believe vaccines will help right now, but medicine, till there's a medicine or a drug, we're all gonna get it at some point or the other. So the best thing we can do is boost our immunity. So that's why we did that.
And actually, it's a national duty. Yeah, and it's a national duty, and you did something remarkable because I don't think that anyone in India have came up with your idea.
Not yet.
How did you came up with the idea actually?
Because, I think what keeps me going is innovation and seeing what else, what's next, what can we do more than this. I'm never happy with just this. So one of the things we saw is situational awareness, and the situation demands that we do something. It's not about people looking good, it's about people feeling good and people being healthy right now. So we said, what can we do to contribute to people being healthy? And that's how we came up with this program.
I see. Doctor, the last question. Do you have any plans for any upcoming online courses or webinars where can our audience join those webinars and learn a lot from you? Because I think with this COVID 19 crisis, we can do a lot of things online. So are you gonna conduct
That
any
is,
further or any upcoming
yeah, I've done a
courses
few
or
webinars recently, and I have a
webinars
few coming
that
up.
our audience
I'll
can
post it on my Instagram.
join it?
I'll post it on my Instagram. So if you follow me on Instagram, you'll
Oh,
get to know when my webinars are, and I'll post the links there. I have a few coming up.
okay, okay, okay. Dr. Shaitra, thank you so much for your time. Thank you so much for your effort. I do highly appreciate your presence. It's like a great pleasure and honor for me. I'm sure that all our audience have learned a lot from you. I hope you liked the webinar that we did today, and thank you so much for your time. And I would like also to thank Mark for organizing this webinar. Please be safe. I hope when all this is over, you may pay us a visit in Egypt as a speaker in a conference or a course. It will be great pleasure for us to have you here.
Thank you,
And
Dr.
please be
Nuri.
safe
You
and
take
take
care and stay
good care of
safe.
yourself.
Thank you.